Good morning, everyone. Welcome and thank you for joining us this morning. My name is Charise Gleason. I'm a nurse practitioner in the multiple myeloma program at Winship Cancer Institute of Emory University. And so today we're going to be talking about updates in myeloma, and there's a lot going on. So I'm going to move quickly through some of this. So I have nothing to disclose. Our objectives, we're going to talk about overview a little bit quickly about myeloma and risk stratification and really how that plays a role both in the upfront and relapse setting. We'll touch base on MRD and just a quick statement on bone health at the end. So just your reminder about myeloma, this is a cancer of the plasma cells where you get this overproliferation of abnormal cells that impact your immunoglobulins. So you get that monoclonal response, not that polyclonal response that you typically see. And that's a picture of what the molecule looks like. When we're working up these patients, we want to make sure that we get both serum and urine studies. So serum protein electrophoresis as well as urine protein electrophoresis. We want complete blood counts and chemistry along with an albumin and a beta-2 microglobulin, as well as an LDH, because that all comes into play with staging. We also want a free light ratio. We want a bone marrow biopsy, and we want to make sure we have FISH and cytogenetics. And then as far as imaging, it's really what your institution has. So for me at Emory, we have PET CTs, and so we're going to want a PET CT at diagnosis, but you might have a whole body low dose CT or a whole body MRI. We also like to get an MRI of the spine at diagnosis, or anytime a patient comes in and they have just maybe a specific pain. You'll notice I don't have skeletal survey on here because we just don't do them anymore unless it's in the context of a clinical trial, because you have to have about 30% bone loss before you're going to see a bone lesion on an X-ray. So in looking, this is just your reminder of what the diagnostic criteria is for symptomatic myeloma, and that CRAB criteria looking for calcium elevation, renal complications, anemia, or bone disease. And then our staging, I just really want you to focus on the revised ISS criteria really takes into consideration abnormal cytogenetics. And you're going to hear me talk about that throughout this talk, because it really helps direct us in our treatment decisions, both in the upfront setting now, as well as relapse. And so this is just putting it out there, what it is, that translocation 414, which by itself is more of a medium risk, but 1416, deletion 17p are a higher risk for those patients. And at deletion 17p, you can have it diagnosis or you can acquire it along the way. High serum LDH as well. And just remember, when you're talking to your patient and you're looking at these things, these are the genes of the plasma cells. And that's sometimes hard for patients to understand. If you look at the survival based on risk, you can see that a standard risk patient is just going to do better with overall survival than a high risk patient. So high risk is high risk. We're going to treat it aggressive throughout, as we'll talk about. So myeloma has a lot of treatments for a rare disease, and you can see the frontline or induction treatments, and it's based on a more gentle approach to a more aggressive. But really, we tend to go with a more aggressive approach. You know, clinical trial after clinical trial have demonstrated that 3 drugs are better than 2, even in a frail population that you might not take to transplant. You just modify the doses at that point. So you really want to think about being aggressive and risk stratifying. So, you know, standard for the backbone of induction therapy for years now has been RVD, that lenalidomide, bortezomib, dexamethasone regimen, and it's a great regimen. But newer clinical trials are telling us we can make it better. For a standard risk patient, the Griffin trial told us if you add daratumumab to that RVD up front, we can make it even better and get a more durable response. For your high risk patient, clinical trials tell us that it's better to go with something like KRD, carfilzomib, lenalidomide, and dexamethasone. So at our institution, if you came in, you're newly diagnosed, we're going to risk stratify you. Our induction for standard risk is DARA RVD. Our induction for high risk is at KRD. Whether we're taking you to transplant or not, like I said, we just modify doses. We're really not going to talk about maintenance today, but just keep in mind, maintenance is considered throughout. Myeloma is a disease of continuous therapy. And then if you look at the relapse setting, all of these drugs, and we're going to talk about some of these newer agents today. So these are just some of those approved drugs you may be familiar with: IMiDs, proteasome inhibitors, anthracyclines, chemotherapy alkylating agents that have been around, and some of those supportive care things that you need to think about with these things, like DVT prophylaxis, infection prevention, antivirals for patients. We see a lot of shingles in myeloma patients. And then how do you get your patient to adhere to that? Steroids, we use a lot of steroid, especially dexamethasone. And so a lot of side effects can come with that. And we tend to hit myeloma regimens with higher doses of steroids up front and then back down off of them. You can see we have an HDAC inhibitor, our monoclonal antibodies, peptide conjugate. Melflufen is a newer drug that was approved this last year. It is not the melphalan that you think of as transplant, that melphalan, it's different. We have an XPO1 inhibitor, and then our first CAR T therapy approved. We also, not on this list, yeah, there it is, I just skipped over it. Belantamab, Mafodotin, our first conjugated antibody. So considerations when we're looking at that first relapse is to think, is this a biochemical versus a symptomatic relapse? Because you don't want to change therapy before you need to. You want those patients to stay on their current therapy as long as they can. And an example of that is I have a patient in clinic that I follow that she's been slowly progressing for the last year and a half. And had we changed her therapy when she initially started to have a number movement, that's a year and a half that we might not have gotten on her next line of therapy. So it's just something to think about. And at that point, we get a PET on that patient just to make sure that there's no extramedullary involvement. So not more going on than what we can see in the lab. So you have to just really watch these patients clinically and look at it. Is that protein doubling and tripling, or is it just slow and not causing them any problems? But when we're picking our next line of therapy, we again want to think about that risk stratification with going with next line. And then you always want to look at your patients. What other comorbidities do they have? What side effects from their previous treatment might they have? And so these are the Apollo, Castor, Candor, and Icaria trials were with monoclonal antibodies for early relapsed myeloma. And these were all phase 3 trials. And you can see they took standard of care and added a monoclonal antibody. And did we make treatment better by 3 drugs versus 2? And they did. If you look at the overall response rate across, when you added the antibody to the standard of care, the overall response rate increased for those patients. So we're going to talk a little bit about monoclonal antibodies. We've been using them for other types of cancer for years, and we've been using them in myeloma for a while. We have 3 that are approved. Daratumumab and isatuximab are both anti-CD38 monoclonal antibodies. Daratumumab now is in the subcutaneous form as well, and we're using daratumumab now up front. Elotuzumab targets the SLAM7, and it's indicated in relapsed refractory myeloma. Isatuximab's indication is relapsed refractory and in combination. Just things to keep in mind with monoclonal antibodies, and this shows you some select adverse events for some of the other agents. But with monoclonal antibodies in particular, especially with the first dose, you do want to pre-med with corticosteroids and antipyretic and antihistamine prior to dosing. With the daratumumab subcutaneous, we've seen the reaction rates go from about 50% down to about 11% with subcutaneous. So we don't see as many reactions. You want to think about herpes zoster throughout, and also with monoclonal antibodies, they can interfere with blood typing and their immunofixation. So you can sometimes see the circulating antibody in there because they're IgG antibodies. The other thing that you want to keep in mind is, so you always want to send a type and screen before that first dosing of a monoclonal antibody, and also check for hepatitis titers prior to first dose. These patients, especially in the combination with monoclonal antibodies, also need a pneumococcal vaccine. So what about myeloma treatment after the first relapse? So, we've got those first relapse options. You can go back to, you still want a triplet therapy. You can give them something they haven't had, or if they had the combination up front and they're progressing on maintenance, you can go back to other drugs that you used up front and just add something new to it. But you can see all the additional options that we have, as we said before. And so we'll look at those a little bit more. You hear a lot about targeting BCMA. So BCMA is a cell surface protein that's highly expressed on myeloma malignant cells. And so many of our newer agents are targeting that. These are some of the BCMA targeted immunotherapies in myeloma, CAR T, you've got bispecifics. As we said, Belantamab was our first bispecific antibody that's been conjugated antibody that's been approved. And then you have your bispecifics that we're using on clinical trials. So the first new drug that I want to talk about is Belantamab Mafodotin. This is an IV drug that's given every 3 weeks. And you can see on the DREAM2 clinical trial, these patients were progressing after 3 or more prior lines of therapy. The overall response rate in a relapsed refractory patient was pretty good, actually. And then the grade 3-4 adverse effects were keratopathy of the epithelia of the eye, thrombocytopenia, anemia. And so it did show anti-myeloma activity. It was approved. And how do we manage those side effects? Because this one's a little bit different when you're presenting a new therapy to a patient, and now we're talking about you can have some vision issues. And typically what we see are very dry eyes and blurry vision. And so these patients have to have a baseline eye exam prior to dosing. And then with subsequent doses before you dose them, they have to have an eye exam before each dosing. And, really, and there's a REMS program grading toxicities. So it's really well tolerated, but you do have to manage the side effects. And if you have a grade 2 change, as you can read here, then you hold the drug, and you can also dose reduce from 2.5 milligrams IV every 3 weeks to 1.9. And so until those changes based on that eye care professional's exam improves or goes back to baseline, you hold the drug. You do want to start eye drops for these patients, preservative-free, about at least 4 times a day. In the clinical trials, they tried steroid drops, and that did not help. So it's not recommended. You also don't want your patient to wear contact lenses unless their eye care specialist says that they can. Bispecific T-cell engagers. These are all on clinical trial. And I'm not going to go into these a lot. I just want you to be aware there are a lot of them. And they're on clinical trials right now. And you can see many of them target BCMA, but a couple don't. And so, you have a patient maybe who's relapsing on a drug that targets BCMA. You might want to look at a bispecific T-cell engager that doesn't target that. We had our first CAR T for myeloma approved this last year in March. Idacaptogen, we call it ide-cel, in relapsed or refractory myeloma patients. So as any CAR T, you have to worry about cytokine release syndrome and neurologic toxicities, and there's a REMS program. So these are the toxicity considerations that you can read through, those adverse events that we saw in more than 20% of patients. So CRS, infections, fatigue, pain. I tell patients when I'm trying to explain it to them before they go in, like the worst flu that you've ever had. You think of those body aches, GI, all those symptoms. We see counts drop. We have to monitor these patients closely, both on the inpatient setting and then when they come back to the clinic, and monitored at least daily for 7 days after CAR T for CRS and neurotoxicity. Selinexor, now this is getting away from BCMA. This inhibits the XPO1 and induces apoptosis. And you can see that XPO1 transports proteins into the nucleus of the cell. The expression is increased in the myeloma, and the XP, it takes it into the cell and causes apoptosis. It's a little bit different than some of the drugs that we've seen. And the kind of toxicities that you see are thrombocytopenia and a lot of GI side effects. So these are patients that you want to aggressively give antiemetics to. So we give aloxapine the night before and then scheduled antiemetics. You can see some hyponatremia with these patients. So these are those patients that you want to eat potato chips and salty things like that. When I mentioned venetoclax, this binds to BCL2, causing apoptosis. And these are targeted therapy for patients who have an 11-14 translocation, which is not a high-risk feature, but something that you see frequently in myeloma. You do have to monitor for tumor lysis, but you don't really see that a lot in myeloma patients like you do some other types of cancers. And common AEs, anemia, thrombocytopenia. The dosing on that for a myeloma patient is 800 milligrams a day. Quickly, I want to mention minimal residual disease. With myeloma, with all of our standard testing, we can get to about right here. And the question is, what happens lower in that microenvironment? Can we get deeper responses? And that's one of the reasons that with giving something like a monoclonal antibody up front, you want to check MRD on these patients. And so at our institution, we check it. If they're going to transplant, that first restaging post-transplant, we take a look, and then annually on those patients. The question is, how often should it be done? There's no consensus. If they're negative, do you stop maintenance? Well, no, because we know that patients who are MRD negative can also progress again. So there's a lot more to learn about this, but it is another prognostic tool that we have for patients, and that way we can use for them. Just want to mention bone modifying agents. These are recommended for all myeloma patients. So pamidronate, zoledronic acid have been around for a long time. They're both IV, and denosumab is a subcutaneous. Typically, again, no consensus on how long, but most people give them in the upfront setting for around 2 years, and then in the relapse setting. And so if you have a patient who's progressing with new bone disease on zoledronic acid, for instance, then you would want to go to denosumab. Something to keep in mind with denosumab is it can really cause hypocalcemia. So you do have to give those patients calcium supplements. So just in conclusion, myeloma remains incurable, but there are so many treatment options for these patients, and we know that triplets and now quadruplets from the start can make these patients overall survival much better. PIs and IMiDs have been around and have been standard of care for a long time. Can we make those better? And is the standard for newly diagnosed myeloma improving outside the context of clinical trials? And high risk remains problematic, and we have to risk stratify throughout and treat those patients more aggressive and different. And there are many new therapies on the horizon, which we went through very quickly, and many more to come. So thank you so much, and please let me know if you have questions.